three common diseases: AMD, diabetic macular edema, and vascular block. And more often, we end up giving anti-VEGFs on a monthly basis. But the problem to the patient is monthly injections again and again and again. And that is a major hassle for most patients. And that is when steroids can act, like triamcinolone used to have about 2 to 2.5 months effect, but the problem is a lot of complications which occur. So that is why we're just trying to cover intravitreal steroid. What is the present current role? Steroids have been used since 1970s and used in more and more diseases. Now, inflammation is a key factor in diabetic macular edema, AMD, as well as vascular blocks. And anti-VEGF is not completely involving basically addressing that inflammation issue. So here, it stabilizes the blood-retinal barrier, down-regulates the inflammatory mediators, which includes the VEGF also, the PEDF and cytokines like TNF-alpha, and reduces expression of matrix metalloproteinase. So commonly used are dexamethasone slow-release implant, that is Ozurdex, triamcinolone acetate, the IVTA, and fluocinolone acetonide, which is going to come in probably. So this is the Ozurdex and that is the fluocinolone implant. So approved uses currently are in central and branch retinal vein occlusion and macular edema, diabetic macular edema, and non-infectious posterior uveitis. So under study like Coats disease, macular edema secondary to retinal vasculitis, Irwan, pseudophakic macular edema, wet AMD, etc. It's okay. It's okay. That's okay. That is just a video of the procedure. I think we will come into the video of the procedure later. So what we are basically going to cover is in diabetic macular edema, triamcinolone acetonide, as Dr. Mahesh pointed out earlier, DRCR.net showed no significant benefit against laser, but in pseudophakic patients it is beneficial. Fluocinolone acetonide slow-release implant showed significant benefit over sham injections over 2 years. FAME trial was a RCT that compared the low dose, the high dose, and sham injections, and at 24 months there was a significant improvement in visual acuity and better risk-benefit ratio compared with the high dose. The low dose was better. Dexamethasone slow-release implant FDA approved in September 2014, and the MEET study group, the percentage of patients with more than 15-letter improvement BCVA from baseline was greater with 0.7 than with 0.35, and that is more than with sham. That's about 22% of people gained about 15 letters. Mean average reduction of CMT also was higher in the 0.7 group. Now this is one patient in whom there was a hard exudate here after multiple anti-VEGF injections. It was not getting controlled, and in this recalcitrant status we gave one Ozurdex, and this is 6 months follow-up. You could see that the hard exudates have reduced and the edema has reduced at 6 months. Macular edema secondary to vein occlusions, triamcinolone. Already vein occlusions can have glaucomas coexisting with it, and so triamcinolone with unacceptably high risk of glaucoma is slightly difficult. The SCORE trial, SCORE BRVO and CRVO did not find a huge evidence, but now Geneva trial, including dexamethasone slow-release implant, showed significant benefit, and about 22% in the 700 microgram group showed benefit more than 15 letters, and 23% in the 350 microgram group. This effect was almost lasting for about, they said 6 months, but I think practically it will last for about 3 to 4 months. Now vein occlusion, this is again another case in which there is a huge macular edema with a single Ozurdex. 6 months post-injection you can have a flat macula like that. In non-infectious posterior uveitis, there was this Retisert, which is tried, that is a fluocinolone implant, but there was an unacceptably high risk of cataract as well as glaucoma in almost all these patients, and all these patients required cataract surgery, and probably about 30% of patients required trabeculectomies. Again, dexamethasone slow-release implant has also been used in non-infectious uveitis. The advantage of this is the pressure rise is not as much. Wet age-related macular degeneration, we do not have an indication yet, but in cases in which the response to anti-VEGF is poor, you could consider combination therapy, and the randomized control trials are on. In pseudophakic macular edema also, randomized control trials showed that there is a benefit with Ozurdex. The only thing is with Subtenon Kenacort, almost all the pseudophakic macular edemas will respond. This is another case where there was a radiation maculopathy. I have about 7 years of follow-up of this patient. He has underwent somewhere around 20 intravitreal Avastin injections, and after that this dexamethasone slow implant showed a significant benefit over the previous injections. So probably in these cases where inflammation plays a huger role In the pathogenesis of macular edema, those can play. This case is a good example for such a thing. Complications are there. Definitely cataract will come in. If you are repeating the Ozurdex injections or triamcinolone injections over 2 years to 3 years, generally cataract is going to form. Raised intraocular pressure is more of a concern with triamcinolone, less of a concern with dexamethasone slow release implant. Injection related problems like subconjunctival hemorrhage, retinal detachment, mind you, this is a larger bore needle. Unlike a 30 gauge needle which you can use with an anti-VEGF, this is a 23 or a 24 gauge needle. Now they have come up with a very sharp needle, but even then there's a problem. Retinal detachment, endophthalmitis is again another problem which can come in, because now we have put steroids inside the eye and any inflammation may be masked. So an endoph will be picked up quite late in the course of events. So pseudo-endophthalmitis or reaction can also happen. Raised IOP, generally it is not much of a concern. In Geneva trial, at 2 months there was a rise in IOP, but most of these cases could be managed by 1 or 2 drugs and none of the patients required any trabeculectomy. But with fluocinolone acetonide, which is longer acting for 2 years or 3 years, the incidence of glaucoma was much higher. As I told you, this is about cataract from the trials. About 28% of the phakic study eyes in the 0.7 group and 19% in the DEX 350 microgram group had cataract. Now we had done a retrospective chart review of all the dexamethasone implant patients between 2011 and 2014 for recalcitrant clinically significant macular edema, and these were about 27 eyes, and the mean logMAR visual acuity 0.6 improved to 0.5 and was maintained at 1 month, 3 months and 6 months. And the mean central macular thickness also significantly improved, which maintained until 6 months. 17 patients had more than 20% reduction in CMT at 1 month, which was maintained in about 40% by 3 months and 28%, that is 6 patients, by the end of 6 months with a single Ozurdex injection. Whereas when the macular edema recurred, many of these patients required a second injection between the 4th and the 5th month. This is the visual acuity graphs and the central macular thickness graphs. So to conclude, triamcinolone right now, as Dr. Mahesh pointed out, I would say that the evidence is only for pseudophakic diabetic macular edema. Dexamethasone slow release implant can be used as a first line agent in vein occlusions, diabetic macular edema and non-infectious posterior uveitis. And fluocinolone acetate, which has not come in yet, can be the drug of choice in non-infectious posterior uveitis in the long term. Thank you very much.